Good afternoon and welcome to today's broadcast of Black Health Trust, the last one of 2025. We're so happy that you chose to join us today. And without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. We have a treat this afternoon. But before we start, I want to inform especially Dr. Walk that I did go to church today. And the sermon was off of John 5. And it's something that the Lord said to a crippled man who'd been crippled for 38 years, who was sitting by a healing pool. And he asked him, "Wilt thou be whole?" And the man went through a whole explanation of why he couldn't get in the pool, why everybody always beat him in there. And Jesus said, "Wilt thou be made whole? Get up, take that cot, and walk." And the whole explanation was, he didn't ask what your identity was, what your politics were, what the problem were. He said, "Would you be made whole?" And our subject today is about things that African Americans are going through mentally and spiritually in their community. And I asked the question, wilt thou be made whole? Despite DEI, Donald Trump, or anybody else, wilt thou be made whole? I'd like to introduce my distinguished brother, who is a past president of the National Medical Association, past president of the Association of Black Psychiatrists, and possibly the upcoming president of the American College of Psychiatry. He's the department chair of psychiatry at LSU in New Orleans, and a good friend, Dr. Ron K. Bailey. Dr. Bailey?
Good afternoon, and thanks for having me, Dr. Maxey, and your entire team. I've been on before, really enjoyed it. I've enjoyed when I listen in, when I'm not the speaker. You do great work in our community. We thank you for it, and happy to join your group today.
Well, thank you. The floor is yours.
Well, basically, for your entire group with Black Health Trust, and begin again by just acknowledging the great work you're doing. I think this started circa the COVID time period. So you're probably at 4 or 5 years now, bringing important, valuable, and essential information, I think, to all communities that are willing to listen, but especially underserved and really under-resourced communities that very often have less access to accurate and important and timely information in general. And that may be double in the mental health space. So I shared with Dr. Maxey, he's mentioned we've been friends a long time. I think Dr. Maxey was president 109 of NMA, and I was president 113. So a mentor of mine, and got a chance to kind of watch a lot of his great work, not only in NMA, but also he chaired and the initial chair. And after that, I had the opportunity to chair the Commission on Health Disparities, jointly led by presidents of the National Medical Association, again, started by Dr. Maxey, and the American Medical Association, through Dr. Nelson. So the reality is we all, stand taller when we work together and grow off earlier work done by persons who led the way. So thank you very much, I think, in that regard. That being said, I have tried to continue my advocacy type work. NMA president, as mentioned, about a decade or so ago, and I am now the sitting president of the Black Psychiatrists of America. Happy to lead that group. Dr. Walks, being an African psychiatrist as well, of course, brings great honor. I won the election 2 years ago in November of 23. It's a 2-year period as president-elect. So I've been preparing during that time period, and we wanted to come on your show once I became president. And that started officially last month at our annual meeting. Generally in the spring, we have a meeting on the Continental 48, a bit more biologically based and medication oriented. And then every fall, 1st of November, we have the so-called transcultural meeting. This year we had it in Grenada, about a month ago. So hot off that item, I'd love to talk today about things we're doing in the BPA and maybe get some feedback and some recommendations, some advice from yourself, Dr. Maxey, or your leadership team, Dr. David Stevens, Dr. Walks and alike, and also I think the members on your audience. Because the reality is we as Black psychiatrists want to be impactful and helpful and beneficial, I think, to our community.
Well, thank you. We're so glad to have you here. Do you have slides?
Well, I'm going to show you slides today. I can if you'd like me to, but I want to really talk about maybe three main issues. One, first and foremost, the Black Psychiatrists of America started in 1969. So we're at year 56 now, if I've done my math correctly. And we've really grown. We now have about 500 members, about 200 what I call senior level paid members, and maybe another 200 or so students and trainees who get kind of free membership. I think that our ability to partner, Dr. Maxey, with other like-minded groups with similar interests has been one of the sine qua non features of the benefit, I think, of BPA, Black Psychiatrists of America. Now we have, inroads with the NMA psychiatry section, and there's a lot of overlap. As you know, I'm BPA president now, and I was section chair of psychiatry in the NMA about 20 years ago now. Our current CEO, the paid employee who runs the organization, Napoleon Higgins, a psychiatrist in Houston, is also a prior BPA president, elected president, and he currently is the section chair for the NMA. So I think we're getting pretty good synergy there. We also have, I think, high quality relationships with other organizations, including the AMA. Now, there's an AMA minority consortium led, at least in part, by Tiffany Bale, a psychiatrist who actually trained under me. When I was chairman at Wake Forest years ago, she did a child fellowship with us. And then I went on to Harvard to get an MBA and focuses on obesity medicine. Just outstanding young sister. And I think our fourth relationship at this point with the through the BPA, with the NMA and with the AMA, but also with the American Psychiatric Association and what's called the Black Caucus of their assembly. We often get 100 Black psychiatrists for that meeting. There are about 1,500 total practicing in the country every day, about 500 male and about twice as many, 1,000 African females. So it gives you a little bit of an idea of the scope of who we are, our numbers. Much of our work, as you might imagine, is done in urban areas. I think about 80% of Black psychiatrists practice within, I think it's 82%, within 100 miles of a metropolitan area of 1 million people or more. So we mainly are an urban-based indigent care operation for many of us working in large institutions, be it jails and prisons and correctional settings. I just when I work now myself, or long-term state hospitals, or community mental health centers. That's very often much of where we are. What we do see now increasingly is many African American psychiatrists hybridizing their work relationships. Some having what I call a hospital job, to put it blunt, early on, but also having an additional private practice. This isn't only an issue, I think, for Black psychiatrists, maybe an issue for psychiatrists in general, because it's just so much more difficult now than in distant past times to simply have an independent private practice. Hard to get paid, hard to get patients. Much of, I think, the market share of patient access occurs in other settings. But I think also many psychiatrists really aim to be engaged and involved in the work that's necessary, I think, in needy communities. That could be our community, others as well, communities of persons who are Hispanic or Native American or like maybe immigrant populations. We do a lot of work in those settings that we're proud of in the BPA, and that's part of the message I wanted to get out today.
So I have a question. Is the fact that the current U.S. administration concentrating on getting rid of so-called diversity, equity, and inclusion, or DEI, is that a hindrance or is that a false flag that we should ignore and do things on our own? How is it affecting the psychology of African Americans?
Oh, I think it's a monumental, catastrophic, and unyielding negative in our community and against our practitioners. And really four key themes to me when we discuss the DEI issue. And just for, fair balance. They're supposed to send a CV. I got it in late, so I apologize to Maxie. But I should certainly share with your audience that I currently also have the title. You mentioned my titles earlier. In fact, I have a new title. As of June of 25, I became Assistant Dean for Health Equity. 2 years ago, June of 23, it became Assistant Dean for Community Engagement. And when I arrived here in New Orleans, June of 21, it was Assistant Dean of Diversity. So from diversity to community engagement to health equity. Because when I came, I was also I had the title of chairman, so I had both these titles. But the reality is, you see many persons in the role that I'm in. Really throughout our history, there's most places that I've worked and trained and been educated. There's often an office within often within the umbrella of the Office of Student Affairs, where there would be some person, hopefully some group of persons, geared to kind of work in this space. At LSU, we have had an associate dean for diversity. Now he's health equity. He's not a chair, but it was a division chief for MFM, maternal fetal medicine in OB/GYN department. But he's actually the senior person in the department and the only full professor academically, interestingly enough. And of course, I came in as the assistant dean of, again, diversity, community engagement, and health equity. But we have had a third employee, a PhD, Dr. Allison Augustus Wallace, who's the director of the Office of Health Equity. And of course, we had a fourth person who's a staff person. So clearly, I think that as those monies have been cut and those programs have been whittled down, if not fully eliminated, it by definition has been more difficult to maintain a lot of the activity and support that we try to provide. It may seem like a small issue, but I'll give you one example. So most years, will sponsor the SMA party. So the SMA is the Student National Medical Association, started in 1964. I thought then, and I still hope, with the relationship with that as an appendage of the National Medical Association, which started in 1895. Most places where I've been, I've trained in Houston. I was on campus faculty at Yale, as assistant instructor level, in fellowship. I've been in Louisiana, and of course, you guys know Tennessee and North Carolina over a 30-year career. And the place I've been, there's been an office of diversity, and it's been funded by soft dollars, i.e., those are monies that at the highest level, the dean's office, for example, provides so you can actually engage in programming activity and not have to spend time fundraising or simply not meet at all. Well, this was probably the first year because we had some leadership changes, I think, at the state level. But we had that function, had it at my house. It was last Friday, the 19th, really without the organizational support and our funding. So clearly, I think I'm proud of our group for working to pull it off. But you can just imagine how much more difficult it is to manage these kind of activities. We do more than just have a party. A lot of it is, prep for it, how to interview and activities of how to write your personal statement, those type of things. If you lose that kind of support, one can imagine how we may see decreases and we have the gains of having more young African Americans, I think, in our work.
But here's my direct question. Is DEI a crutch that we shouldn't count on anymore? We need to serve our community without DEI or concerned about what the administration does. Who cares?
Well, no, I say it differently. I've never thought, and it's a long answer. I'll try to be short. I clearly understand in the world that we're in, we have to kind of deal with real, temporal politics. And much of the discourse, I think, unfortunate, but I'm willing to acknowledge in our society, because of course it comes from, I think, very often persons who may be pointed in their approach, is that DEI or diversity initiatives assist individuals who are underqualified or unqualified to then rise to a high level and function as if they were qualified. We can only think about the guy that unfortunately died recently and made the comment that's gone viral that if he got on an airplane and the pilot was African American, he would think certain things as if that just simply having an African American skin would make that person unqualified or uneducated or things of that nature. But I've actually never thought that. I think that like most people, considerations are correct. They're just unfortunately in the minority in the media. I've always thought that in a world we're in, I guess the example would be there are more people qualified to do the jobs generally than the spots we have. Med schools are a great example. I was on admissions committee in Texas years ago. We get 2,600 applications for 200 spots. Clearly, more than 200 or 201 people who qualify to get to medical school. So a lot goes into trying to decide how a person is going to be accepted. But once you appreciate that all of them, so many of them are qualified, you get away from this whole underqualified conversation. That being said, if DEI goes away, and there are many who are working very hard to make that happen, what will simply occur is it'll be more difficult for persons who were qualified for jobs and positions and spots in medical schools, for example, to have their voice heard, to even have their application looked at, to have a fighting chance to be engaged or involved. That I think is a detriment to our society because we need the best qualified people to move forward professionally.
Dr. Barbara Neighbor-Stevens.
Well, I want to change the subject a little bit. I do have, if time permits, I want to come back to the DEI question. But given that it appears that on January 1, millions of people are going to lose their health insurance and therefore have limited access to needed health services, what or how, um, what suggestions would you give our audience in terms of how to navigate? And it was already a very tight market. It's not unusual to have to wait months for an appointment with a psychiatrist. You may get in to see a social worker or somebody before then, but to actually get in to see the psychiatrist, the waiting list are long because the supply is short. Now, couple that with problems with insurance and access, what suggestions do you have to the community how they can meet their behavioral health needs?
Fair point. And I think that is, I love the way you context it, Dr. Neighbor-Stevens, because the reality is I think that we as physicians, as providers of care, period, let alone those of us who hail from communities that have been historically under-resourced, need to have a plan and need to think of doing some things differently. And if I heard you correctly, that certainly is, I think, is exactly how you context the question, and I commend you for it. I'll give my own best example. I have started, and this probably started, before it started, more than a year ago now, but I think it's really so important now, having moved myself to a model where persons need to be able to call me and be able to get in for an appointment in 7 days or less. And it's difficult to do that in part because once you take people, period, if they stay with you, then your schedule fills up. So what many persons have when they can't get in at all is the so-called closed practice. And although that may sound good financially, if all your spots filled and all your money's going to come in, it's very bad for the community if they can't get in and access your expertise. If you're a doctor of any sort, let alone hopefully a culturally competent doctor in mental health specialty. So what I've had to do on the backside is develop relationships with other entities, other persons who see persons after I got in for a first visit. Some doctors in primary care who choose to write psychiatric medications, other primary care doctors won't do it, will take referrals from me for what I call the follow-up to the follow-up. I also am very fortunate I'm in an academic setting, so I have a wealth of residents. At LSU, we have 80 residents, 20 per year at 3 different sites. So it's like the 6th largest psychiatry residency in the country. So that, of course, I know I have a big advantage in that setting. But also have learned that with maybe more than one or two, but it doesn't have to be 10 direct conversations with the primary care doctor, I can generally get them to feel comfortable and confident enough to write or refill the meds that the person is receiving. So often the struggle getting into a psychiatrist is this issue about timing, but what the person really needs to do is to see the psychiatrist for the initial visit, or sometimes it'll be 2 or 3 visits, but not necessarily 16 visits or 52 visits once a week for a year. And that's what I think very often blocks up your schedule. Now, I tried to change that when I got to LSU 5 years ago, not just because I thought it was not optimal for us to be valuable in our community. I wanted the LSU doctors to be taking care of all people in the New Orleans community. So they just have open schedules, not closed schedules. But it's also financially beneficial for the office for us to be doing more new visits than a lot of repeat visits. So it's taken quite a bit of a push. I don't think, in all honesty, that was as successful as I would have liked to have been, really making this kind of wide open. I think psychiatrists should be seeing practically all new visits, to be honest with you, because there's that many people trying to get in for visits. Maybe not all, but majority should be new visits and not persons you've seen over a lot of period of time. And many of the some of the subsequent to new visits, visit 2, visit 3, I understand. But when you on to visit 10 and 12 and 15 and 52, very often that's a stable patient who can be moved to a primary care provider and sometimes even a mid-level. But people need to get in to see psychiatrists for new visits. And I think it's our job as African psychiatrists to make ourselves available to do that.
Thank you. Dr. Walks?
Thank you, Dr. Maxey. Dr. Bailey, it's always great just to connect with you, and it's certainly a privilege and an honor when we have you here with us on Black Health Trust. I want to focus on your really relatively unique position, being the head of a large mental health organization. And last time you were here, you talked about some of the relationships you have from LSU with other entities and what have you. So my question would be, one, can you tell us a little bit more about what you're doing with some of these other partners, and then also how that joint work or that partnering that you do impacts what we call the stigma, impacts the normalization of mental health in the community? And then I got like 15 other questions, but if you can just talk a little bit about that one.
I certainly can. Well, thanks very much, Dr. Walks. A lot of work, I think, in this space. And you correctly, a little bit about what we've done in trying to kind of run an organization that has had a history that's been a bit up and down in regards to what we're trying to accomplish now. So a little bit of history. I think we've been on this site since 1931. So when I was hired in June of 21, it was 90 years on the ground. LSU had a Department of Psychiatry. We probably got a residency, I think, in the 60s or so. So that was not all 90 years, maybe about half of the amount of time. But, never been a Black chairman. Very happy being in that role, very proud and the like, if you will, very humbled. I love to say to people, it's a perfect example of the fact that, you need DEI. I'm classically somebody who says, and I shout it to the mountaintops, I'm absolutely a DEI hire and proud of it. I think that there have been a wealth of Black human beings, male and female, not only qualified and competent, but would have been outstanding chairman, but because of the challenges in our society, they didn't get a chance to do that. What DEI did, probably from the federal level, is it made it pretty clear that schools should be at least mindful of issues regarding cultural competence in the practice of psychiatric medicine. Louisiana is 2/3 Black. It's one-third Black as a population, 1.5 million out of 4.5 million people. And New Orleans is 2/3 Black, about 600,000 out of 900,000 people. So in those kind of settings, they've never had an African-American person as chairman, not just of psychiatry. They've been a chairman in anything, in medicine, surgery, pediatrics, anesthesia, at Shreveport or in New Orleans or Baton Rouge, in basic sciences or clinical sciences. So I give Steve Nelson credit for search and find. I'm not from here. I was working at UCLA in California. They called me. So clearly there was an interest in deciding, let's try to find if we can find qualified individuals. I don't think I'd ever get into a conversation with anybody who think that my CV wasn't as strong as anybody's, period, in that setting. And we've had a lot of success on the ground. So I think that the story that has to be told, and I'm enjoying telling it to you guys today, we discussed it at the BPA National Meeting in Grenada, and I'm going to discuss it a lot for the next 2 years, is the real story of DEI. And that's why I like Dr. Maxey's question, is that there are many people of different backgrounds, Hispanic and white and Black and Asian, who are qualified for roles, probably more than the number of roles that we have in those settings. But we have to push at an intentional level to make persons who are choosing persons for big roles look at everybody. If you don't mind, I'll squeeze an example in. I hope we're good on time. I think it's really the best example I can ever give on DEI. And I don't think she'd be mad about it, but this is actually my wife. Got a smart wife, majored in engineering, blah, blah, blah. She was in college, this is 40 years ago now, going to what they call, we call it internship. They call it whatever word to use for it. You go and spend the summer every other semester, co-op, they call it co-op, with the engineers at a program. And the story is that we can say this now, I don't think we should fear any retribution, that, she put her numbers in or a CV and that kind of business and the like. And the story is that the person in charge threw her CV, her resume in the garbage can. And we only got that because we got it from a very good source who was there on site. Another person who probably should have done it, but did it, and we hope she'll go to heaven for it. She didn't lose a job for it. Took the application out of the garbage can and put it back in the pack. So the whole pack probably went blinded to the job, and the job probably had three people were going to pick out of 100, and hers was picked. So she got a chance to do the to do the role. So for me, it's just incredible. I mean, I've been around these situations my whole life, that it's not so much that persons are being pushed up who are not qualified, is you got to get a chance for that's content, just on process to get through the opportunity to be viewed at all. Therefore, you then see that you actually have comparable, if not even sometimes even better skills. And that's a story that in Black Scotch of America, we've got to tell, we got to tell it proudly.
So let me just point out that whenever I get on an airplane and I see the black pilot, I feel better because I know that him or her or they really must be really, really good to be flying that big airplane because they don't let us do that. So
Yeah. So if you want to go there, we'll say more. I know it's a taped conversation, but I'm gonna say it as best I can. And I've been telling this story, I guess, off the record for 40 years now, 30, so I'll tell it now. When I was in medical school, there was a lot of discussion about people taking exams. And I went to medical school that required all exams be under what they call the honor system. So there was no proctor there. There was no teacher there, whatever the case may be. And over my 4 years there was a fair amount of discussion about what would happen when people go to the bathroom. You'd have to leave the room, if you will. And if your audience is following me clearly, I hope they are. I want you to know that I went to 4 years of medical school and I never went to the bathroom. And that's a bit funny, a bit jocular. Of course, I mean, I went to the bathroom doing an exam. And I can't say that everybody did that, but that gives you an idea, not only about the extra level of pressure on individuals, but why you know that a guy who never went to the bathroom take an exam. I'm telling a story as honest as I can to you 40 years later, 30 years later, I guess, if you will. There's not a chance that person didn't mark those Scantron sheets correctly and get those questions right to pass those tests. It's possible that somebody else who went to the bathroom a lot during exams may have had a different circumstance. Is that fair? Is that a fair way to put it, Dr. Maxey?
Yeah, I congratulate you on the strength of your kidneys. Is Dr. Hines
Dr. Maxey, it's not the strength of the kidneys, it's young kidneys.
Young kidneys.
Young kidneys can do that.
okay, is Dr. Hines on?
Dr.
No,
Hines is not with us today.
What about Dr. Lawson?
no.
I don't see Dr. Lawson today.
All right. Anything in the chat?
While we're looking in the chat, I really want to ask Dr. Bailey if he can share with us some of the policy priorities of the organizations that he is working on. We really have to. I think we really have to look at where we put our strengths and where we focus. What are the primary things that we are trying to do?
I'd say that for me, these barriers are real and they are perceptible, but they're not impenetrable, and they're not impossible to deal with it, to address it, to overcome. And I have to say this. I mean, I know I made a lot of comments kind of in the vernacular. Some people in the chat just kind of talk about my kidneys. Trust me, I mean, these are 2-hour exams. I don't want to make this sound like more than it was. I mean, you took a 2-hour exam when I go to the bathroom. So it wasn't a major sacrifice. You before you go, and then when the exam is over, you turn your exam and you leave. So the point obviously is just that you don't take any chance of somebody saying, "Where were you doing the exam?" And
I understand that. I was just
right,
trying
I'm with you.
Exactly.
But having young kids is still helpful. You're right. But I think that Ivan makes a more than timely point. I mean, the reality is not only must we be mindful. I think we have to be diligent and a bit more focused. Getting back to Dr. Maxey's earlier point, there are barriers, whether it's DEI or otherwise. I heard you, Dr. Maxey. There are increasing barriers on what we do on our young people. Again, I had that party at my house on the 19th, and I spent time trying to talk to every person there. We had about 40, 35 or 40 African American medical students who were there one on one, get a little more to the side. And after you pass the initial perfunctory, hello, how you doing, or whatever, many persons there had some concern, some issue. There'd been some conflict, there'd been some difficulty. So very often, Black students learn to smile and try to move past it because you carry a big emotional burden that people realize. But it is real and it is there. That's why I think it's important to have African American faculty, or if you're not African American, you at least want to be culturally competent and be aware of how much more difficult it is for people African American. That's important as well. I think it's also essential to have programs. I think programs bring some formality to what you're trying to do to keep young people on the right track, moving forward and trying to be successful. And the biggest issue I'd say is that I think the other thing that these programs, be they diversity offices or the like, what they can do is when you begin to have the beginning or the precipice of difficulty, there's somebody to go to and they can intervene on your behalf. In fact, that same party, I was talking to a guy who's in orthopedic surgery. And what he was saying is that he's really encouraging young persons to come to LSU to train orthopedic surgery because he's telling them that if you have some difficulty, you can come to me early and I can help point you in the right direction. We think we keep finding many young AA individuals, they don't know where to go if they get into a residency and there's some trouble, there's some difficulty, somebody's writing them up in the wrong way, and they think they're being treated unfairly. And boy, I tell you, once that spiral starts going in a negative direction, it can be difficult to stop it. And we think that's one reason why there's so many African American residents who are pushed out of residencies. And in the BPA, we find it objectionable. And one of my main goals, my second or fourth point I'll make today, is to bring the program that I've been involved in now for about 15 years. I think I told you guys about it. I've had what I call a residency, an extern program, who help young people who the train got off the right track earlier and trying to get back on the right track, make a better score on a standardized exam. Maybe they started a program and had to stop. Maybe they had a health difficulty. Maybe they didn't have a good letter recommendation from the dean's letter, and that kind of hindered them. But for many persons, there's some difficulty that caused them to have some challenge. I wrote an article about it, and I can get that to your audience, to your group, Dr. Maxine, published in Academic Psychiatry in 2019, where we kind of talk about this. And it's a huge issue because many people across the country have trouble getting into these residencies, and many Black people have even more trouble staying in and finishing. So matriculation and graduation, I think, is one of our challenges.
May I make a comment on that? I said I wanted to say something about DEI,
Go
and
ahead.
I too need to be quite mindful that this is a taped program. But what I want to emphasize is that my reaction to the implementation of DEI rubbed me the wrong way. And the reason it rubbed me the wrong way was because I felt strongly that it was an attempt to do two things. One was to neutralize, if not abolish, the impact that affirmative action had once when it started. And I'm a child of that period. The other thing that bothered me about DEI, and what I mean by that is it was diluting it from the goal of affirmative action and broadening it, and I would say diminishing the impact of the effort because of the broadening of the effort. The second part of it that bothered me was I believe a spade should be called a spade. And DEI was an attempt to avoid dealing with the root cause of the problem. I think I said it nicely.
You said it nicely.
Dr. Bailey?
Yeah, well, I think if I hear Dr. Stevens correctly, if she's saying that, at times there are attempts in policy or in legislation to, cover up a bigger sin and mistreatment of people and unfairness and bias and frank, policies that I think hinder persons from functioning is a big sin. Okay. All right. Okay, well, I'll be here for sure. So I think that that certainly could be the case. I've never been sort of against the not just this one, but other forms of incremental progress. 'Cause I think that that may be better than not having any progress at all. But if you're saying that persons had some folks call them quotas to avoid what they really should have done was to make a fair playing field. I wouldn't disagree with that at all. I think that a fair playing field overall would be best. That's what you really wish at the highest level, our government and even private enterprises, that they would foster, or that they would encourage, or they would allow.
Let me depend on what Dr. Neighbor Stevens was saying. How do you think the effects of artificial intelligence are affecting our young people? And also, there was a case a few weeks ago where a famous movie producer got killed by a son who was using drugs. And one of the things that came out was that he got his medication changed a few days before he murdered both of his parents. So we have an epidemic of young men being unhinged. I'd like your comment on that and how AI or screen time is affecting that.
Well, as you point out, I think that the first issue of the movie producer being killed, period, let alone in a heinous way, period, let alone by his son, is certainly more than tragic. And we, like all people, take a moment to pause and acknowledge the tragedy of unrequited violence. When it happens at the hands of somebody that is not, a stranger or, Chester the molester and that type of business, I mean, that is, fraternal and familial. And it's unfortunate about the data is that more murders happen like that than the other. We spend a lot of time putting burglar bars on our house to keep the strangers out. The person who's most likely to hurt you is somebody that knows you. That's who's most likely to murder you, most likely to sexually assault you. People who live inside your house after you close the doors and lock the doors against the bad guys. I think the issue about AI is a unique one. I, like all of us, am trying to catch up, understand, be on the right page. I literally, before I hopped on with you today, was reading about a professor at the college who was saying that he had talked to students and had to fail some because they had used AI to do their work. And more than one kind of came back in to talk to him and say, well, I only use AI for the references. And they really thought that that meant that they were still okay. So he was giving this long explanation about how students in college, don't appreciate that you have to, do the work on your own. It has to be authentic. It has to be yours. And then the thoughts and ideas that be germinated, autonomously. And AI considerably can alter that. For us in psychiatry, it's a huge deal, Dr. Maxey, because we believe that AI is, early on, BD thought that we would not be affected by it because the doctor-patient relationship has to be so strong between mental professionals like psychiatry and others. But there's some now that think you can teach the machine to know how to show empathy and to do talk therapy and know what to say based on what was stated earlier. I think the jury's still out for that. My gut reaction is that there's so much that's required in fostering and maintaining and optimizing high level doctor-patient relationship in the type of therapy that I've been involved in throughout my career, that I am aware that there can be some human value that you just cannot replace in a non-human setting. We'll see whether I'm right or wrong, but those are my thoughts. I do think, though, that for many others, especially because there's such a business side to medicine, there's going to be a Herculean attempt to find ways to alleviate the need for many mental health professionals, MDs and otherwise, PhDs and master's level therapists, because of course, very often you can pay the machine by at one time and you think you're saving money over time. So I think this is going to be a pox that we're going to have to deal with in mental health going forward.
Thank you. Dr. Walks?
Yeah, I really wanted to follow up on where you just left it, Dr. Bailey, because we've had screening tools for a long time in mental health. We've had depression screening, anxiety screening, all of that. And there's always been an understanding that it was a screening tool, but you still had to have the human talking with the other human to fully understand that individual's experience of whatever the screening tool was telling us might be the problem. And so my concern, I share your concern. I don't know how we're ever going to get the person out of this very, very personal interaction around mental health. And I see things going that way horribly. We hear these stories about someone was talking to one of these AI systems and giving them really, really bad advice to the point of maybe you ought to kill yourself and things like that. So I think we have to be diligent about where it goes. One of the areas I think where Dr. Maxey's question was going is, as people are developing AI, how are you at a top-notch academic institution? Are you able to make sure that there is some of the us in that sauce? Because if AI is developed without us, it'll be like all those medications that never get tested on us and then don't work the same way on us.
Well, that's a perfect perspective, Dr. Walks, to take, and I think it can't be said better than the way you stated it. That's exactly why I think cultural competence matters. That's exactly why I think, regardless of your culture, experience matters. It's also, I think, exactly why there has to be an appropriate match. My mother called it, before I was a doctor, when I was a young kid, you got to have a good therapeutic alliance. So I would say that she's the second, she's the smartest doctor in my family. I was having the third, because you guys know I got a daughter who's a doctor, now. Part of my personal fun talk. But this idea of a therapeutic alliance does matter. There have been people who, for any number of reasons, in my 30 years of doing this business, it worked and it clicked and it made sense. There's some that it didn't at first, and I worked very diligently to understand and try to be a better listener, to go to some reading about the things that was happening with them or what have you. I remember early in my career, we used to do the issue with the window, and the professor could be behind the window, kind of watching. And I'll just, in full disclosure, share which group to the Dr. Maxey and Dr. Walks I'm talking to, that my professor, right or wrong, I'm not here to say he was right or wrong or whatever, challenged me at times, which I think you should do. You'll make me get better about my engagement with patients who may have been not necessarily broadcasting it, but who he thought were LGBT or had those concerns. And I guess he was trying to teach me or train me, which is his job, and I accepted it, to be more mindful, to more watchful, be more sensitive to cues that may have been occurring that in individual therapy, he thought I may have been missing or missed opportunities to provide better care for this individual. And so I read a lot during those days about that engagement, trying to understand. Again, I finished residency in mid school in 1990. So we're talking 35 years ago. A wealth of changes occurred in our profession in that space since then. But then it was still something that needed to be done and addressed. So I think to Dr. Walks's point, I clearly think that there's a component of being involved in putting these programs together that will require an intellectual base. You have to know the X's and O's of psychiatry, but it also has to require a culturally competent base. And as I like to say, you don't have to be Black to be culturally competent to take care of Black patients any more than I, as a man, have to be a woman to be culturally competent to take care of all women patients. But I probably got to think somewhat differently and engage with a woman patient in a way that's helpful for her, that may be different than every man patient I take care of. And that's my responsibility as a psychiatrist to know how to do that and do that piece well. That may be a classic area that the AI instrument may not be able to do as well as a human.
Well, expanding on that line of thought, is there a way with the organizations that we mutually belong to, the NMA, the Black Psychiatrists, et cetera, that we can program AI to be culturally sensitive and competent? Is there a way that we can do that through our journals and literature that we have access to and the patient? Because most of the data out there at the National Library of Medicine, et cetera, may be biased. How can we unbias that data?
Well, that's a great point. I think that it's not a uniform system. All professionals who are Black don't see this exactly the same any more than all persons who are Black vote in a national presidential election exactly the same. So the reality is, it's not a perfect, match to say if you have an African American provider, a psychiatrist, psychologist, they by definition are going to get it. They're going to understand for a number of reasons. I mean, just because somebody has the same skin tone doesn't mean they can't come with the same circumstances. I'm the first to say that it'd be hard for me to be in a setting with a young man and they've really had a hard life, and for me to try to act as if I have, because I have not. I grew up what you call in this country about as middle class as you could be. I'm an only child. My parents are school teachers, and we really never had any kind of major catastrophe. Just that alone makes you a lot more middle class than probably 60% of the persons who kind of grew up in America. As far as the money you have and things of that nature, if you will. The other piece, though, I think, is that experience does matter. And for some people, even whether you grew up middle class or, less thereof, or with a lot of resources, some may have had an experience that was actually very, very problematic for them. And what we train in psychiatry to try to do is to try to empathize and understand and place yourself at some point in that person's shoes so you'll be able to understand that point. And that's where the remorse comes in. And if the person thinks you can really feel their pain, understand that circumstance, then it may be a lot more likely to have the kind of trust and confidence in you. This develops a therapeutic alliance, and you can kind of move forward, and then you can have a conversation at a very different level. What many would argue, for example, if you're not culturally competent, is you as the clinician, the doctor, the psychiatrist, for example, does or says something very early on, and that sends a signal to them that you're not engaged, that you're not culturally competent, that you don't get it, you're not listening to them, you're not really, you're repeating things incorrectly. They say something from one perspective of life, and you respond in an entirely different genre. So there's a lot of signals that you can send as a professional that communicate to the patient the wrong message. And I think that's a piece that we try to train young people in mental health and in psychiatry as to how to do this job better or well. And sometimes patients vote with their feet. If you're just not very good at it, they don't come back. They leave. And others at some point, will feel differently and will come back, but will tell others to come. And those are some subjective considerations of how we can tell if the quality of therapy matters to the person who you're trying to take care of.
I'd like to ask you, and this may be the last question as we get into the top of the hour, but the issues that we've been talking about around DEI and the need for supportive um, organizations to help young professionals um, make it in their training and early careers is not limited. The problem is not limited to young doctors. It's across the board, and we've talked about the institutional dynamics that are creating issues for these young people. My question is, what do we need to start doing differently or more of with our young people, starting as early as kindergarten or even just before school? I mean, what are the things, the dynamics? I mean, I have my ideas about it, but I'm not going to say mine. But what are the things that as a community we need to start doing a better job of as we raise our children so that they are equipped to deal with these institutional dynamics that are unfortunately at play across the board in American life?
Well, I love the question because I try to answer this. I get a chance to answer it a lot in other settings, and I keep trying to get better at my answers. So I think I'm better than I used to be, but I'm still not as good as I need to be. So let me tell you, it's a work in progress. But let me take a shot at it. I believe either or both is kind of how I look at it. And the vernacular would be, on one hand, you could kind of push through a life where you really try to push the envelope on all of the issues that I think where relative fairness and equity should occur. When it doesn't occur, you can kind of stay in the mix of it, kind of fight through it. You can kind of appeal your way to keep trying to get a second look, if you will. And that may be the life that many of us who went into medicine are engaged in. Because, very often we were in settings that maybe were not indicative of fairness and equity. Maybe there was a fair amount of unfairness and the like. If you didn't quit, you stayed through it. Maybe you received some, slaps across the bow, so to speak, literally, if not metaphorically. I remember a friend of mine was spit on by the resident when they were, asking him questions in residency. When they asked you questions in the morning, guy was trying to intimidate him, so he got right in front of his face. He was spitting in his face. He knew he was spitting in his face, but he acted like he was just asking questions real close to him. So those kind of humiliating actions, you witnessed this as a resident. But some of us have a mindset, I'm going to get through. And when some of us got through, I mean, here I am now, a 62-year-old guy, and I'm 30 years out of UTMB, Galveston, and they asked me to run the alumni, what do you call it, the alumni 30-year reunion kind of meeting or whatever. It's all great now, probably because I got the job as chairman of LSU. If I don't deal with this guy spitting in my face 30 years ago, if I yell at him or punch him in the face or curse him out or whatever, you never get through med school, you never get to residency, you never really kind of move forward. But on the other hand, I think it's very reasonable to say that's not the plight for every person or every Black person or every ethnic minority or gender minority who is trying to figure out the way to go forward. Some folks, that's not their plight to try to fight those battles and have a 30-year period trying to kind of get to the top of the food chain. Some are going to kind of leave that setting, try to go on their own, do it on their own, and try to avoid those kinds of concerns blocking them from moving forward. I in no way am against that. I support it fully. I think what we probably should do, to answer your question more directly, Larry Stevens, is try to talk to young people and tell them that these are probably, if there's a metaphorical fork on the road, these are two different directions to go down. You probably, once you choose, you know what you're likely to expect going forward. Pros and cons both ways, but at least understand where you are, not to feel, that you've been blocked and you can't move forward at all in your own ability to have progress. We want young African Americans to have the same opportunity others have to have progress successfully in their professional lives.
Thank you. We're at the top of the hour. We appreciate you being with us today, Dr. Bailey. We'd like some final comments for you before co-moderators comment.
Yeah, I would end in 30 seconds by saying, obviously, thanks for having me. Wonderful show. I think I started off by saying it earlier. Very happy to be in this new role as the president of the Black Psychiatrists of America. And I've been in this role for 2 years, from November 25 until November 27. I didn't talk a whole lot about it today, but I would just share that we have 4 big meetings in your 2 years, and mine I'm targeting 2 on the continental 48 that are more of our biological meetings. We hope to be in New Orleans at LSU in March of 26, and in Houston, New Medical School there, University of Houston, in March of 27. And the 2 so-called transculturals, we plan to go to the continent of Africa, to Accra, Ghana, November of 26, and then they have a transcultural meeting, but in Washington, D.C., on the continent of 48, November of 27. The ones on the continent of 48 are fiscally more beneficial for us because we get more outside resources. The companies that support us can do so on the continent of 48, not when we go to the Caribbean or away. Our numbers are growing. We may one day look up at that 500 dues paid members and the 1,500 Black psychiatrists alive and working in this country. So we hope to be a voice to be reckoned with by doing and saying the things that I think are germane as a trade organization to support our members and as an advocacy organization to support our community. Thanks for having me.
Thank you so much. If you can, one day I would like you to track down an old friend of mine named Nell Prin. I'd like to get a hold of her.
I can certainly do it.
Okay. Dr. Wilkes?
Thank you, Dr. Maxey. Dr. Bailey, like I said before, man, it's always good to see you, and it's always good to know that you are continuing to press the fight forward. It is important that folks like you that have the scholarship and the energy um, continue to press things forward. So just look forward to always seeing you. And as you already know, if there's anything I can do to support, encourage, or push somebody out of the way as you're moving forward with your tasks and your opportunities, just let me know.
Dr. Walks, his energy comes from being young.
Well, look, he can sprint 100 yards, but I can still sprint about 5. So maybe I can just do a little short sprint. He might need something like that. I can do a short sprint before my hamstring lets up.
We
Dr.
want
Barbara,
your help.
Dr. Barbara Davis Stevens.
Well, thank you, Dr. Bailey, for coming and sharing with us your activities, which I am sure that you will succeed in quite admirably. But what I want to comment on is that it is so important that the community know, because there's not going to be a lot of talk about what you're doing for lots of reasons that a lot of them we've talked about today. But we're going to have to start blowing our own horns a bit more so that the community is aware of what is available and who there is that they can turn to, and where there may be opportunities for linkages or whatever the need is. So I'm so happy that we had this show today, and I look forward to us having more like it so that the good work that's being done gets the due notice that it deserves.
Well, I appreciate you.
And Dr. Bailey, thank you so much for the help you've done in our programming, both in the past and recently. With the doctors you've referred to us, we welcome you back as soon as you're available. We know you're very busy, but we want you back. And what's the next book you got coming out?
Great question. So we are working on a book that we are trying to finish in December of 25. That means I've done in my last 2 or 3 days, but I think I'm a bit behind. I think this will probably be the first quarter of 26. Hope the book will be in hand by Christmas of 26. It's on adolescent violence, and I just share with this group that my second book was on gun violence in 2018, and my third book was on domestic violence in 2021. So if this one comes out 26, similar with both of those, as I was writing the last book, a lot of the indices are pointing toward a need to write on this new topic. So a lot of focus on domestic violence in writing a gun violence book, a tremendous amount of focus on adolescent violence in writing a domestic violence book. That's going with to us being here now. A lot to talk about when I come back, but I would simply say a lot of the focus, there's 3 terms I leave with your group today, and I'd love to come back and talk about it. One is epigenetics. We did a really deep dive in the socialization of the genetic foundation of particularly the focus, I think, on young adolescents and why they're violent. Another focus in much regard, I think, is just on this issue of construction bias and confirmation bias, and how that adversely impacts how many of our young people are acculturated to think and grow and feel. And if you're always back on your heels, you're a lot more likely to strike out aggressively. And then the final point, of course, is just the whole issue we always talk a lot about gun violence, access to weapons, but a huge issue then on this idea of being able to essentially to refrain from highest level violent activity. One name I'll use, and I know guys like you guys know it well, and I'll probably quote him extensively, but Carl Bell, great guy, and we know he's in heaven now, but he liked to say adolescents are all gas and no brakes. And I have that theme running throughout a lot of what I'm considering what I'm writing here. So love to come back and talk about adolescent violence, maybe sometime in the new year.
Well, thank you so much. I really appreciate you a lot. Come back as much as you can. And I also would look forward to seeing you in the new year. Simon, thank you very much for today. Dr. Walks, Dr. Barbara Davis Stevens. We'll be back next week as usual in the new year. Happy New Year, everyone.
Happy New Year, everyone.
Happy New Year.